When you see a question on your NCLEX exam about a patient with chronic kidney disease, your mind must immediately jump to the most critical risks. Imagine this scenario. A patient with stage 4 CKD presents with a rising creatinine level, minimal urine output over the last 8 hours, and a serum potassium of 6.8 milliequivalents per liter. The monitor shows peaked T waves. What is your first and most immediate concern? Is it preparing for dialysis, administering a diuretic, assessing for fluid overload, or protecting the heart from dysrhythmias? The correct thinking process always prioritizes immediate life threats. In this case, you must think, protect the heart. High potassium is a cardiac emergency. This focused essay will guide you through essential CKD facts so you can identify priorities and choose correct answers fast. So, what exactly is chronic kidney disease, abbreviated CKD? CKD means the kidneys are damaged and can no longer filter blood properly. The damage is progressive and long-term, developing over months or years, unlike acute kidney injury, which can be sudden and reversible. CKD damage is typically permanent. Kidneys remove waste and excess fluid to make urine. When filtration declines, urea and creatinine build up and fluid and electrolyte balance becomes dangerous. The two leading causes are diabetes, high blood sugar damages kidney vessels, hypertension, chronic high pressure injures arteries and reduces renal blood flow. Managing blood sugar and blood pressure is critical. Other causes include glomerulonephritis, polycystic disease, obstruction, infections, and nephrotoxic drugs, especially NSAIDs like ibuprofen. CKD progresses through 5 stages based on the glomerular filtration rate, or GFR, the amount of blood filtered per minute and best overall indicator of kidney function. For the NCLEX memorized stages, management depends on them. Think of GFR like % kidney function. It helps anticipate problems and plan care. Stage 1, GFR 8/90, normal function but with damage like proteinuria or abnormal imaging. Stage 2, 60/89, often asymptomatic, focus on glucose, BP, lifestyle and adherence. Stage 3A, 45-59, 3B, 30-44, moderate loss with anemia, bone disease, fatigue, swelling, monitor labs and meds closely. Stage 4, 15-29, severe loss, expect fatigue, edema, nausea, prepare for dialysis or transplant. Stage 5, end stage, GFR 15, renal replacement is necessary. Without it, toxin and fluid buildup are fatal. Always remember, in CKD, the heart often leads your priorities. For the NCLEX, you must interpret key CKD labs. These numbers tell the story and guide interventions. Watch serum creatinine and BUN. Creatinine rises as kidney function falls. Trends matter more than single values. BUN also rises but can reflect dehydration or high-protein diet. eGFR remains the best measure, calculated from creatinine plus age, sex, and race. It declines steadily as CKD progresses. Nursing priorities: protect your patient. Safety is number 1. Manage life-threatening complications. First, cardiac status with hyperkalemia. K+, 6.5 needs continuous monitoring. EKG changes demand immediate continuous monitoring. Recognize VT and VF, intervene swiftly. This is a core NCLEX safety focus. Second, fluid balance. Overload causes hypertension, edema and pulmonary edema. Daily same-time weights, strict INO, frequent BP checks, listen for crackles. If SOB and crackles, sit upright and notify the provider. Third, medication safety. Renally cleared drugs can accumulate. Check dosing for eGFR. Adjust antibiotics, digoxin and hypoglycemics. Avoid NSAIDs. Question orders that don't fit a low GFR. Hemodialysis access, fistula, graft, catheter requires strict aseptic technique. Watch for infection signs and report promptly. Sepsis can develop fast. Managing CKD, diet, meds and renal replacement. Diet restricts sodium and potassium, limit high potassium foods, restrict phosphorus, limit dairy, nuts, processed foods. Pre-dialysis, moderate protein restriction. On dialysis, increase high-quality protein. Manage fluid intake to prevent overload. Meds, control BP with ACE inhibitors and ARBs. Treat anemia with epoetin alpha and iron. Use phosphate binders at meals, sevelamer, calcium acetate, and activated vitamin D like calcitriol. RRT, hemodialysis 3 times weekly via fistula or graft, or peritoneal dialysis at home daily. Compare methods. Best long-term solution is transplant, but it requires major surgery and lifelong immunosuppression. Match therapy to stage, goals, and safety. Clear, simple teaching saves lives. Weigh every morning after urinating before eating on the same scale and report sudden gains over 2 to 3 pounds in a day. Watch for increased swelling and new shortness of breath. Understand each medication and avoid NSAIDs, ibuprofen, Advil, Motrin, naproxen, Aleve unless the nephrologist approves. Always consult before taking new OTCs, supplements or herbals. Take phosphate binders with meals, never on an empty stomach. Keep diet simple. Limit a short list of high K foods, choose lower K alternatives and avoid adding salt in cooking or at the table. Choose low sodium labels. Manage thirst with measured ice chips and hard candy. For fistula or graft, feel the thrill, listen for the brute. Never BP, blood draws or IVs in the access arm. Protect this arm, it is their lifeline. For peritoneal dialysis, cloudy fluid, abdominal pain, fever require prompt action. Always use sterile technique during exchanges. Empowered patients prevent complications and avoid hospitalizations. Memory aids and a final exam checklist. Prioritize complications. K is key for cardiac. Check potassium and the ECG first. Treatment planning. GFR equals guide for RX. Staging drives dosing and dialysis timing. Weigh and watch. Daily weights for fluid overload. No NSAIDs, no kidding. A critical safety teaching. 1. Identify the stage by eGFR. Early 1, 2, moderate 3, severe 4, end stage 5. 2. Look at potassium and ECG. If high K plus and EKG changes, protect the heart immediately. 3. Assess fluid, weight gain, edema, crackles, and elevated BP. 4. Review meds for renal dosing and avoid NSAIDs. 5. Protect the dialysis access, fistula, graft or catheter. 6. Prioritize discharge teaching, diet, meds, daily weights, and access care. CKD is progressive, master stages, guard the heart, manage fluid, ensure med safety, and teach clearly. Keep stage, potassium, fluid, meds, access, teaching front and center, and pass with confidence.